Hi, my name is Marla O'Keefe. Welcome to the workshop, Infections After Transplants. I'd like to thank Takeda Pharmaceutical Company, whose support helped make this workshop possible. It is my pleasure to introduce Dr. Shivan Shah. Dr. Shah is an onco-transplant infectious disease physician at Houston Methodist Hospital, where he works with the oncology and stem cell transplant teams to treat patients who have various oncology or transplant-related infections. Dr. Shah's clinical interests include onco-transplant infections, infections in leukemia and lymphoma, respiratory infections, and travel medicine. Please join me in welcoming Dr. Shah.
Hello, this is Dr. Shivan Shah, one of the oncotransplant infectious disease physicians at Houston Methodist Hospital. Today, I just want to briefly talk about these infections after transplant. It's a pretty wide area, and a lot of questions, especially in today's world we're having with infections. So go ahead. No disclosures for me at this time. So today's objectives are we want to kind of establish what's the importance of having an infectious disease consultation before and after a stem cell transplant. Also, we'll go over risk factors for developing infections. Then we'll talk about what are ways we can minimize risk. There's various ways, and also that will include what are things that we need to do for ongoing care after a transplant. And lastly, we'll briefly touch on COVID-19. It'll just be a brief point on a few slides about it. So, infectious disease in our stem cell population, it's a fairly recent thing that we've kind of been involved in. Previous to this, infectious disease was really known as like an HIV type of consultation. HIV was the last large epidemic pandemic we kind of had in the States. But now, because of the increased amount of bone marrow transplant or stem cell patients we're also seeing a lot of opportunistic infections. And if not diagnosed early enough, we can see a higher mortality. Basically, we're here to help you as patients and families to kind of navigate through the world of these infections. Infections will always be here. They'll never go away. But, with some help, we can kind of hopefully get them cured. So this is just one of the graphs that we have showing the amount of transplants that have been slowly kind of increasing throughout the year in the U.S. This just goes up to 2015. However, it's gone up much higher in past years, except for the past 2 years where COVID started, where, unfortunately, it was more difficult to start doing transplants. So another slide kind of showing the different types of transplant and their increasing amount. Basically, just wanted to show that, the more transplants we do, the more chances of infections we have, and the more times we will likely be consulted. And unfortunately, you may have to see us for an infection. So now we'll go into risk factors for infection. The biggest risk factor that we have is the type of transplant. The type of transplant that you get usually will determine the days to engraftment. Days to engraftment are, of course, when the blood counts recover. That's when you're engrafted, and the time that you aren't engrafted is the highest risk of getting any type of infection. Autologous transplants, where we use the patient's own stem cells, the engraftment occurs much earlier, 10 days, before 10 days usually. Allogeneic stem cells, so donor cells, will usually take between 14 to 30 days, and even longer. These are the average times, but there are always outliers for both. And the longer time you're without white blood cells, the higher risk you have for more infection. The next slide that we have is just a graph showing phases of predictable immune suppression and associated opportunistic infections. I just wanted to it's a pretty large slide, but I kind of just wanted to show that before day 180, so in the 6-month mark, that's where you get most of your infections. It is the highest risk of opportunistic infections and also contagious infections you can get from family members or if you're outside somewhere. We usually tell our patients at the 6-month time, after that, it's a little safer if they want to do something. But before that, it gets a little risky. You can get infections varying from fungal, bacterial, viral, or parasitic infections. However, even after 6 months, there is a risk factor, but the immunosuppression is much less, so it's less risky. Other risk factors we have is that basically when an infectious disease physician is interviewing you, we want to find out all about your life. You'll have an infectious disease physician come in the room and discuss your hobbies, where you were born, profession, vaccine status, sexual history, pets and animals that you own or in contact with, and then a history of infections. What this helps us formulate is what are your risk factors. We've had patients that would be carpentry enthusiasts. They would buy wood from Papua New Guinea and they developed a fungal infection from the wood from Papua New Guinea. So even just the slightest clue can help us figure out, what type of infection you can have. And our transplant patients are the most trickiest because they don't present with infections like the rest of the population does. They'll maybe just have a fever, but they won't present with any other symptoms. So it's our job to help kind of navigate through this and diagnose what's going on. Steps that we can use to reduce the risk of transplant-related infections. Usually pre-transplant, again, an evaluation by an infectious disease doctor with some, pre-transplant labs and clinical history. Typically, our pre-transplant labs are varying from just serology testings and testing for other types of maybe enteric parasites that, especially if you traveled, we may want to know. Post-transplant, we want to make sure you're on the right prophylactic anti-infectives. So you'll see when you get a transplant, you'll be on some antivirals and some antibacterials for a given time, especially in the 6-month time to prevent any sort of infections or most infections from happening. However, there are always breakthroughs and people can develop infections. Other things that we do post-transplant are vaccines. So that's one thing. We'll touch on that in a little bit. The risk of disease and death is less in patients who actually follow these recommendations, take their medications, and you'll see, drastic changes in you being admitted to the hospital if you're compliant with the medication. So the most common bacterial etiologies that we see in our patients that get transplant, number one, what we've seen is usually strep pneumo. It is a bacteria that actually causes pneumonia. There is a vaccine for it, and it's one of the ones that we can prevent, especially with a vaccination. It is, however, treatable with antibiotics. It's spread through pneumonia. Person to person can get it, unfortunately, but it is not as contagious as a viral infection. You have to be in very close contact. Strep viridans or streptococci typically is, you can see it as a blood-borne bacteria. It usually does happen by the drying up of your mucosal lining of your mouth, and it can cause a bloodstream infection. The way we kind of treat that or prevent it is usually a prophylactic antibiotic after your transplant, making sure you have good oral care. HIV, which is Hemophilus B, there's a vaccine for it. We've seen it less because of the vaccine, but again, prophylactic antibiotics help out with it. And lastly, Bordetella pertussis is one of the major ones. It's a droplet type of infectious disease. The treatment is an antibiotic. However, again, it's preventable with the vaccine. We get it with the Tdap vaccine, which you can get as a booster every so often in clinics. So, basically, the viral infections that we have, CMV, HSV, and VZV, all of these we test beforehand on you to see. We do a serology testing. CMV is a disease that many of the world's population already has in their body, but it doesn't present itself till you end up having immunosuppression. So after a transplant, it is very, very important that your physician or your primary doctor monitors this, especially if you're IgG positive prior to transplant. It's not really contagious per se, in the matter of that if you have it, you'll spread it to everyone because, again, most of the world population already has it. Prophylaxis is with a medication called valganciclovir. We also have other medications now called letermovir and maribavir that are just released, and they work very well against preventing this infection. HSV, very common, cold sores, genital herpes as well. We have the best way of preventing is a prophylaxis with Valtrex. It's another antiviral, very commonly used. And lastly, VZV. VZV is zoster or shingles, we call it. We can test for VZV IgG, but if anyone with a history of chickenpox will likely have this already in their system, and they can reactivate after a transplant. This is one that we use contact and airborne precaution. So if you have a large shingles outbreak on your body, those vesicles that form on there can burst, and actually it can be airborne, and it can become contagious to the person nearby you. Basically, the best prevention for this is getting the vaccine. And there is a new vaccine now that we can use for our transplant people, which I will talk about shortly. So vaccinations pre and post transplant. So this is a list of transplants. As you can see, most of them you could give after 6 months. The pneumonia vaccine, the PCV13, you can do after 3 months, but the PCV23, which is a broader one that you will give, usually is 12 months after transplant. Influenza, you could give 4 months after transplant. However, during times of major epidemics or pandemics, it might be required to give it a little sooner. And the recombinant zoster vaccine, we want to do 50 to 70 days post-transplant. And then a second dose we could do about 2 months later. These are all in protocol. We have many eyes looking to make sure you have all these done. But most of them you'll get after 6 months. Now, there's a list of contraindicated vaccines. I write this, and we'll talk a little bit about it right now. So any live vaccine, it can be very detrimental early on. Influenza, we have a non-live vaccine, so we prefer to give that. MMR, now recently, and this is current news, measles has gone up in very high amounts across the world. And there are many studies that during times of pandemics or epidemics, it is okay to give it earlier. Typically, all these contraindicated vaccines, if needed to give, you give after 2 years. However, in times of epidemics or pandemics, you can give it after a year. Earlier than a year may be risky and cause, unfortunately, some sort of reaction or reactivation of a virus and infection. So it is something to be aware of. So a big problem that we're seeing recently is, getting family members vaccinated. During the COVID pandemic, it was very difficult because, people had to isolate. We had to make sure we got vaccines to everyone. So it is imperative that your family is given routine vaccinations if they want to keep you safe. We call it kind of cocooning the patient, keeping the patient safe, especially in those first year. It is, very important. During COVID pandemics especially, we want to make sure that this is done. COVID is very contagious. So lifestyle changes, we'll kind of go over that to help minimize risk of infections. So Bacterial infections are a very common thing we see. As you can see, I've kind of listed a few: Campylobacter, Listeria, E. coli, Salmonella, Shigella, Vibrio, and Yersinia. These are all foodborne pathogens that we can get, and they can actually cause disseminated infections in a few of these. You'd be surprised. There will be dietary recommendations and restrictions that you'll have, but certain things, will be a big no-no. One of the big things I'll say is anything unpasteurized, definitely would avoid. This is not to scary. This is not to say you can never have a salad again, of course, but be aware. There are outbreaks in packaged salads. Soft cheeses can also be very risky. Poultry, again, you have to cook it very thoroughly. Make sure you wash your hands and everything. Salmonella, I wrote reptiles. It's just one of the clinical clues we always have. Some people own pet turtles and things, and you can actually develop a disseminated salmonella infection from that. So the biggest thing is to make sure is anytime you're going to have these type of foods, it's usually better to eat, warm cooked food versus cold food, and avoid raw foods. That's the biggest thing. Food contamination can occur in many forms. Raw, uncooked meals. Unfortunately, we will see fecal matter from animals. It's farm food. It'll happen. And then unpasteurized products, including orange juice. So you got to be careful. Pasteurization is a form of, helping kill off bacteria. It's a good thing. We want that to happen. So if you pasteurize, you make sure you drink pasteurized only things, especially, if you're traveling. It's very difficult to kind of see what is a clean drink versus a not clean drink. Raw honey, deli meats, raw shellfish, again, are also problems. A rule of thumb, like I said, cooked food is always better than cold food. Viruses and parasites in food. So many viruses can cause chronic illness. A big one I would say is called norovirus. People can have chronic norovirus, so they're not really, unfortunately, related to foods a lot of times it can be related to other items, and it can be contagious from person to person, and it's just fecal oral route, so it can be from fecal matter from animals or even humans. Unfortunately, it can be contaminating things. So wash your hands, and wash your hands. Parasites are very uncommon in the USA. However, if you're traveling around the world, you can definitely get it. They are not unheard of over here, but these are things that, as an ID physician, we could test for and figure out. When you're traveling outside the country, stick to bottled water and hot foods. Never use ice from the street. Unfortunately, people will go to a cafe and order a juice or a soda and get ice, and unfortunately, they'll become ill. And I've seen many infections because of this. Pets, animals, and children. So our pets and other animals. So pets are, very dependent. We all love our dogs and cats, and they're very dependent on us. The first 6 months after transplant, it is very, very important to have a social network to help, people to help you out with the animal that you have. You should not be cleaning up their feces or urine, as I kind of discussed before. And if you have any exotic animals, now by exotic animals, birds, reptiles, even snakes, things like that, you could develop some infections that are very bad. They can be parasitic, fungal, things like that. I would avoid them completely. The biggest thing is, get help, and try not to, take care of them on your own, of course. Definitely do not need to get rid of them completely, but it's very important to make sure that you're clean and you don't, aren't taking care of their fecal matter and urine. Children, if you have children, young children, and you need to get a bone marrow transplant, just before a transplant happens, there should be a plan within the household. Kids, they will get many illnesses, especially viral illnesses at school, hanging around other kids. If they go to Chuck E. Cheese's, they'll pick up something. They will not always present with symptoms. They are very mild symptoms. They might just get a runny nose one day or a one-time fever. I'm not saying to avoid our children, of course, but you should consider masking and other precautions, somewhat isolating if you need to, especially within the first 6 months, like I discussed. First 6 months are very crucial. Consider distancing during those times if you want your mask off, and then hand washing for everyone in the household, not just yourself. It's a big must. Routine care, pretty much, that we're going to talk about what you do after a transplant, what is routine care to help avoid certain infections. So oral health, big major player. I get a lot of consults in the hospital regarding mucositis or ulcers in the mouth and things like that. After a transplant, the mucosa can become extremely dry. This is called xerostomia. You hear us talk about that. It's because of low saliva flow. When you have low saliva flow, the moisture is gone, and oral bacterial flora can sneak into bad areas of the teeth, inside the teeth, to look for that flora. They'll die out otherwise if it's too dry in your mouth. You'll get cavities, you'll get dental abscesses, and in a patient with a transplant, these can be very, very indolent or very slow growing that you won't present till a while, and people can miss it, and then it can get to the point where it infects the upper bone, and it may require surgery. So we want to prevent all that. The best way of doing that is undergoing an evaluation with your dentist that you have, or developing a rapport with the dentist. Typically, we say 6 months to 12 months going to them to make sure everything's okay, just routine care. If you have any mucositis or ulcers in the mouth or pain, we prescribe salt and baking soda rinse, which is essentially like a magic mouthwash as well, and it'll help kind of relieve those symptoms, and it'll help kind of develop some moisture in the mouth as well. Foot care. So feet, unfortunately, are one of the most ignored parts of the body. People can miss it. People do not want the doctor. They always wear socks. They don't want the doctor to look at their feet. However, feet can develop a lot of cuts and cracks, which can lead to infections. Transplant patients are more prone to fungal diseases, especially fungal infections of the feet, commonly known as athlete's foot. But there are other types of fungus that we can see on the feet, especially in the nail bed. It is our job as infectious disease physicians to make sure we monitor your feet too. When you come in, if you develop fever, first thing I do is look at the feet. Other areas too that we see indolent infections: feet, mouth, and even the rectal area, the buttocks area. So you'll see an infectious disease doctor, make sure he's looking through all those, at least the initial round whenever we see you for a fever or such. If these aren't taken care of early on, they can develop into systemic infections, and I've seen a foot infection cause a infection of the eye because the fungus traveled from the foot to the bloodstream. And if we catch it early on, we can take care of it early on and make sure everything's okay. So it's very important for patients and their families to make sure they're looking at their feet and nothing new is popping up, they're not having pain. Try not to ignore it. Also, make sure you go see a podiatrist. And the last part, we'll briefly talk about COVID-19. There is another seminar for this, I'm aware, but this will be just a short talk about it. So past 2 years, this was an image that we took off of Google. It just had their count in the U.S. So we're heading into May now, and luckily the numbers are down right now. However, they are starting to creep back up. So it's something we need to stay vigilant about. What do you know about COVID-19, or what do I know about COVID-19? We know it's highly contagious. Vaccines, do they help? And if we get it, how we can treat it. So these are things that we're kind of discuss. COVID-19. So we use a term called R0. So that R0 that you see down there, it's called R0. It's a value that we give to see how contagious it is. Now, this isn't fully up to date, but I'll talk about the newer variants while we go over this graph. The original strain, as you can see, it's one person can infect 3 people. The 1918 flu or Ebola, it's one person can infect 2 people. Now, as we progress forward, we started seeing the Delta strain. It started getting a little more contagious, so one would infect 7 people. Going over towards the complete right side, we see measles, which is regarded as an infectious disease as one of the most contagious viruses out there, and it can be very deadly. And as you can see, it infects many people. One infects 18 people. What we were seeing, the Omicron variant was between that time. It was between 12 and 18 people. So Omicron was extremely, extremely contagious. We were seeing patients filling up our hospitals during the initial Omicron, and it infected a wide variety of people. Unfortunately, transplant people ended up becoming a little sicker when I was seeing them. But we had some treatments, which I will go over next. But it's very important to know that we are still, we could still develop another variant that can be just as contagious and may evade our natural immunity or vaccinated immunity. The vaccines for COVID, this is just a study that was kind of early on. We showed that there was a higher response rate for stem cell transplant patients and a good response rate who got the 2 doses of the Pfizer mRNA. Now we're kind of in this position of multiple boosters. The 3rd booster showed positive effect, and the 4th booster, there are studies that showed that it's beneficial as well, especially just in our immunocompromised. We have to weigh the risks and benefits of the side effects, and I'll briefly go over some of the side effects that people have been worried about right now. So the number one that I've seen and heard about is myocarditis, that people get very scared about this. What we do know about this myocarditis, it was found in the very young population, the teens, in fact. And what we do know as well is myocarditis was actually found more in patients who developed COVID-19 or who got COVID-19 versus the patients who got the vaccine. So the vaccines actually lowered the risk of myocarditis versus increasing it. Clots were another thing that people have been scared about, but we do know after many patients that clots form likely from the inflammatory reaction of the COVID virus and not the vaccine. We saw that it was less clots found in the vaccinated population. So that was very important to know, and it kind of calms the nerves of many people, many patients that I had. Treatments for our stem cell patients who develop COVID. So this is ongoing changing. I have to get an update every week regarding this. So currently we've developed new oral medications called Paxlovid, Molnupiravir, and Paxlovid just became a little more on the news that it's going to be more available. Paxlovid is also one of the medications that has a lot of side effects or drug-drug interactions. It is highly important you discuss this with your primary doctor or your transplant doctor or even your infectious disease doctor to make sure it's not interacting with your medications. If you're on immunosuppressive medications for GVHD or things like that, it can interact with them and cause toxicity of those medications. So very important to discuss it. Do not take it without consulting with your physician first. They work pretty effectively for preventing progression. However, patients who get COVID-19 that are still in that pre-engraftment period or highly immunosuppressed on steroids or GVHD medications, they can develop longer COVID shedding, and it may not help out with that. The monoclonal antibodies, we've gotten pretty much a new one for every variant because the old ones don't work for the current variant, so we have to continue with new ones. They're a one-time infusion. They work pretty effectively in preventing severe progression of COVID. Many hospitals, at our hospital too, we see this happening. We see that we can give it pretty easily outpatient, preventing the patient from having to be admitted to the hospital. So it's something that your local hospital should have and you should be able to get referred to, especially being a stem cell transplant patient. There's certain qualifications, age, obesity, but being a stem cell patient is one of those qualifications to receive it, and definitely recommend that as one of the first lines for our transplant individuals. Remdesivir is our IV formulation of the antiviral that we use in the hospital. There was a new study that was done showing 3 days of it for mild COVID should be enough. However, it's very difficult to know if we need a longer duration in our stem cell transplant patients. who develop COVID. There is no prophylaxis with it, unfortunately. It's usually just for treatment. So we want to make sure that, if you develop worsening COVID, that's something you should receive. And it should help out with it. Other medications that I didn't really show on here right now, steroids is one if you develop severe COVID. However, many of our stem cell patients develop GVHD and they're already on steroids, so we may need to increase those steroids if they develop a pneumonia from COVID. Some older medications I've been studying that do not work. Hydroxychloroquine, it's been very studied now. A lot of clinical trials have actually been done now. Shows that there's no benefit. Ivermectin as well as another one. I know there's been a lot of news about it, but it just does not show any benefit. Azithromycin as an antibiotic did not show any benefit as well. And convalescent plasma, initially there was some benefit to it, but the monoclonal antibodies work much better. What I do want to convey is all these medications will have side effects, and even ivermectin, hydroxychloroquine, they have their side effects. They can cause heart arrhythmias. Ivermectin could cause a lot of diarrhea and neurotoxicity. So be careful, whenever you take all this. Again, consult with your physicians, transplant team, and your infectious disease physician if you have any questions about this. The future of COVID, just a brief slide. It's going to take a lot of changes still to help out with it. Still trying to get the vaccine out, coming out with a newer vaccine that kind of covers all the COVID variants, so we don't need to continue with many different boosters and such. Adaptive immunity to SARS-CoV virus, which we're in the phase of kind of getting to. It's turning into this maybe herd immunity / we're understanding that we may be out of the pandemic phase of COVID and into an endemic phase. We may get seasonal variations of this. Strict policy changes, not to say it needs to be quarantined all the time, but maybe some early pandemic responses for future pandemics again, because just as a warning, this will not be the last pandemic in your lifetime likely, and we'll see more in the future, unfortunately. That is the end of my presentation right now. We'll start the questions.
Thank you, Dr. Shah, for that excellent presentation. We will now take some questions. As a reminder, if you have a question, please type it into the chat box on the lower left-hand corner of your screen. First question, regarding the bacterial infections, do the recommendations regarding cooked foods primarily apply to the first 6 months post-transplant, first year, or permanently?
Good question. So what I will say is the highest risk you have is within that first year. I recommend, at least in that first 6 months, cooked hot foods. However, if you want to eat some cold foods like cold salads and things like that after the 6-month mark, that is fine. It also depends on the type of transplant you got as well and how long you were engrafted, how long it took you to engraft. Permanently, usually things aren't that permanent. However, just as a caveat to that, anytime you eat raw food, so raw oysters, beef tartare, things like that, even if you're not immunosuppressed, you have a risk of catching infection. But if you are immunosuppressed, it's a higher risk. Again, if you're traveling outside the country, it's better safe than sorry. If you know it's a reputable restaurant or you're cooking at home and you wanted something like that, then it's a little safer, of course. But you have to be a little careful. And even for myself, I'm not immunosuppressed, but I tend to, if I'm traveling around, I make sure, I stick to hot foods more than the cold foods.
Thank you. Next question. I have had both an auto and an allo transplant. In the past 5 years, I've had 4 blood infections, pneumonia twice, lung infections, and a brain infection of listeria. Is it possible that my immune system was suppressed too much in an effort to manage my chronic GVHD?
So, good question. Basically, because of your chronic GVHD, the risk is, and since you've had both types of transplants in the past year, listeria is a known pathogen, and like we discussed kind of before, to cause these type of infections. And it's very difficult to diagnose a lot of times. It takes a little bit of effort, imaging and LPs to do lumbar punctures to get done. If your GVHD wasn't suppressed using immunosuppressants, then you would have other problems going on too. You could have gotten a lot of issues regarding your gut, your liver, even respiratory GVHD. That could lead to other problems. It's a seesaw, unfortunately. So we have to balance your risk of infection versus your risk of getting GVHD complications. What we consider in this, if it's a Listeria, some other bacteria, sometimes we just put you on prophylaxis for life with an antibiotic to make sure, it doesn't break through on there. But, again, you can always develop another type of infection.
Thank you. Next question. If you are more than 2 years post-transplant but still on low-dose tacrolimus, 1.5 milligrams, can you get the live vaccines? Second part of the question is also, do you still need the antibiotic and antivirals?
So, good question. So the live vaccine, it just depends on which live vaccine. This is going to be something to discuss. Typically, if you're on tacrolimus and you're on for GVHD, we usually try to avoid the live vaccines. Now we're getting a lot more of the inactive vaccines that we can use, and like for shingles vaccine, the Shingrix, we can use that now for to prevent shingles. But there are certain ones that we have to avoid because the risk is you can actually develop the infection itself when you get it. Now, if you're not very immunosuppressed, if it's a very low dose, there's a risk and benefit situation. But most of the times we try to avoid that. And the second part of the question with the antivirals and the antibiotics, this depends also on your history of infection. Now, if you're a high-risk individual with CMV or things like that, we may need to continue your antiviral. Or if you have a history of herpes, you may need the other antiviral, the Valtrex. A history of recurrent infections with bacteria, then you need to be on the antibiotic still. Typically, after 1 year, we avoid the antibiotic, but with an antiviral, and if you're on tacrolimus, we will continue your antiviral. Now, there are some bacteria that there are some antibiotics we use to prevent fungal infections, but like PJP, which you're on Bactrim for usually, but we usually give that to prevent that infection. Now, again, it's the best choices to discuss with your physician and regarding these questions because they'll know your case, and every case will be individualized.
Thank you. This is a question about bottled water. Should people look for distilled, spring, or something else, or does it matter?
Typically, that doesn't matter as long as it's bottled and not. So you got to be careful in certain countries and actually around the world. You can find bottled water that's not really bottled. So you got to make sure it's a truly bottled water that was packaged and not packaged by them. They can reseal, recycle water bottles all the time. So just be careful with that. But it doesn't matter which type of water it is.
Okay. Next question. If 2 shingle vaccines were given while on immunosuppressants, are they effective on tacrolimus and Jakafi?
Yes, they can be effective. However, there is a risk that is less effective. Now, the benefit of redosing again, there may not be, especially if you're still on your tacrolimus and Jakafi. But there is effectiveness. Any vaccine will still have effectiveness. It just may not be as high as a person who is immunocompetent or less immunosuppressed.
Thank you. I am 100 days post-auto transplant. Do you recommend avoiding air travel until I am 6 months post-transplant? I am 65 years old.
So if it's air travel, so there was a study done. If it's air travel domestically, it may not be as you may not need to avoid as much if it's important. Now, if you can delay this to 6 months, it'll be better. Also, judging on the creeping the COVID infections that we're seeing, the creeping up of it, and also the mask mandates off in the planes, so many people aren't wearing it. So it is a higher risk. Luckily, the planes have a high HEPA filter recycling, and they found that it was a lot better for filtering out infections in these planes. However, if you could wait past 6 months, it might be better, just to avoid current types of infections that are going on, viral infections and such.
Thank you. What is considered immunosuppressed or immunocompromised as it relates to vaccines? I'm 4 years post-auto transplant and take no immunosuppressants.
So typically after 2 years after a transplant, and you're not on any immunosuppressants or high-dose steroids, you would be considered a history of immunosuppression. You still, because you're a transplant patient, we would still consider you somewhat immunosuppressed because of that history. We'd always have to look out for it. However, you would be placed in another category when it comes to infections in my mind. I would not be concerned about you obtaining any fungal infections or things like that. It's a good question. It's always, again, everyone's individual. So if somehow you were put on high-dose steroids, you would be considered immunosuppressed. But if you're not on any steroids or anything, you're more functioning like a immunocompetent person than you are as an immunosuppressed person.
The MMR vaccine is generally not given till 2 years after transplant, but I see several papers showing no problems at 1 year. What is your opinion and experience? I want to go overseas.
So, briefly, I think I touched on this in the presentation. During times of pandemics or epidemics of measles, there have been an okay to give it after 1 year. And there are papers showing that it's okay to do that. This is definitely a risk-benefit talk to have with your transplant team and an infectious disease doctor. Personally, I would be okay after 1 year to give it, especially if you're going to an area that may have an outbreak going on, if it's absolutely necessary to go to. Again, we would always say try to avoid it. Measles is very contagious, but if you have to go, then it's okay.
Thank you. Next question. I am on hydrocortisone for adrenal replacement as a result of metastasis. Would this make me immunosuppressed? I am 2.5 years post-auto transplant.
So, good question. So hydrocortisone, interestingly enough, is a steroid that is not considered a corticosteroid. It's a mineralocorticosteroid. It doesn't have the same properties to cause severe immunosuppression. However, because of metastasis and things like that, you needing medication to bring it up, your body may not produce also steroids efficiently. We would still put you under the immunosuppressed category while you're taking that, but again, you wouldn't be at risk of certain infections compared to other people. So you would still be a little more immunosuppressed than I would hope to, and I'd still look out for things, and I would, watch out. But again, hydrocortisone is not as immunosuppressive as other like prednisone and things like that.
Thank you. Is there ever a time when my immune system will go back to where it was before the transplant, which I had in auto, taking into consideration that I have followed all the instructions from my transplant doctor?
Again, it's individualized. Yes, there could be, but again, you're always at risk. That this is just with the genetics and things like that. We're hoping after an auto transplant, things kind of improve and you're completely different genetics at that point. It kind of got rid of the cancer, but again, once you have cancer, there's always a risk of getting it again. So you could, again, unfortunately relapse, which we don't hope for, but that's always why you gotta look for it. Now, if you're not on immunosuppressives, like I said before, no immunosuppressives, no steroids, nothing like that, you're closer to your immunocompetency than you were, during transplant. You're much, much closer. I'd say even like 99, or not 99, but 95% close enough. So there's always a risk. You'll probably have a little more risk compared to someone without any history of stem cell, but you're close enough that it'd be okay.
We have a couple food-related questions. I think you answered some in the beginning. I'll combine these. How soon after the transplant can I go back to eating salads or soft cheeses? And what about fresh fruit that I wash myself?
So salads, well, soft cheeses, always be careful with. Again, soft cheeses in general. One of the big things is Listeria. In general, it's a risk. If you're on GVHD medications and such, it's very hard for you to go back to that. But if you're not on any GVHD medications, if it's an auto, after 2 years, perfectly fine, probably to go back to all that. Salads, after, I'd say usually a year, I would give it. It's just one of those things that you have to be a little careful about. And then fresh fruit, washing yourself, always good. Typically it's tricky sometimes, I don't want to refrain from people from eating fruit, but again, I usually give it like 6 months to a year. Things that you wash yourself or you grow yourself, make sure, it's fine. Again, there's outbreaks all the time in these things. If you go to the CDC, you can find local outbreaks going on. So there was a little E. coli outbreak in salad packages the other month. So we were seeing that happen. So unfortunately, it's hard to kind of navigate through it. Typically, you want to avoid it within the first year, but then after that, it's a little easier to do.
Thank you. Next question. I am 50 years old and 8 years post-transplant. I had the Pneumova 24 back in my first year, but not since. Do I need to get any more as I get older?
Yes. Sorry, what was the age again of it?
50 years old, 8 years post-transplant.
Yeah. Yeah, you will need to get it again. There is actually newer guidelines out. Your primary care physician will be able to determine the time you get it. Usually, we give it, after the age of 60 to 65. It all depends on what we see also immunosuppressant wise. So I would definitely go back and discuss with them. You will need it again though.
Thank you. What do you do when a patient who should be on antibiotics for life ends up with C. diff from being on antibiotics? Is the C. diff more dire?
So great question. Yes, and I didn't really touch on this, but all types of antibiotics will have the risk of catching C. diff, which is an infection that you get from taking antibiotics. It's spores in your gut, and when you suppress your gut from antibiotics, these spores come out and cause havoc and diarrhea. So C. diff, basically, it depends on how bad of a C. diff infection you have. I've placed patients on prophylactic C. diff medication, especially if they need suppressive antibiotics for other things. So patients who have joint infections and they needed suppressive antibiotics, we've given prophylactic PO vancomycin to prevent C. diff from coming back for life. Other things that you can eventually lead into are fecal transplants, which are you take healthy fecal matter from a patient and you transplant it into someone's gut, meaning you do a colonoscopy, a sigmoidoscopy, and you give them good feces. But that is ways we've kind of helped treat these patients. But typically, because most of these patients are in acute phase and they're going to be on immunosuppressives or antibiotics for life, I'll give them prophylactic PO vancomycin after they're treated for their C. diff, and eventually try to follow up with them for maybe a fecal transplant in the future.
I am 1 year post-transplant. I am not on immunosuppression. I do have mild GVHD in the liver, skin, mouth, joints, and eyes. As I consider visiting friends with kids, if I mask, is staying over their house for a weekend considered high-risk behavior?
So typically, if you're not on any, now it's 1 year post and you have mild GVHD, high risk, yes, if you're very close with the children, I'd say, and again, viruses could spread very easily throughout children and the family members there, so it could be considered somewhat high risk. if you're able to, wear an N95, so the surgical masks are better for preventing spreading, but it won't prevent you from kind of inhaling it. The N95 masks are better for filtering it out. So if you're able to do that, kind of maintain some social distancing, it's okay. But again, it is still a little risky, especially with school in session and things like that. It also depends on the age of the child, of course.
Thank you. My platelet count always reads between 140 and 143. How can I get it to go higher? Let's say 155 or higher. I am 51 months post-transplant.
Okay. So the platelet count, I'll say the platelet count unfortunately deals more with the hematology team rather than the infectious team. So unfortunately, I won't be able to properly answer this question, but it's something. Platelets usually take the longest time to come back, from my experience in this, and this is something that I would definitely discuss with your oncology team and your transplant team regarding this. They might, need to see if there's other reasons for that happening, but typically platelets are usually the last thing to come back after a transplant.
Thank you. At what month can a transplant patient do yard work, and what kind of infection can I get from the plants and the soil?
Great question. So typically I would wait after 1 year, 100%. If you're doing yard work, gloves and a mask are highly important even after that 1 year. Typical infections you could get from yards are there's fungal infections that we look for, Fusarium, Aspergillus, things like that. They're mold infections. You will initially be on mold prophylaxis after your transplant. Usually, if you're especially an allo, they give it to you at least for 6 months, if not 1 year, depending on how immunosuppressed you're going to be. But there are so many more other infections you can also get from it that it may be hard to prevent it, especially within that 1 year mark. After 1 year, it's okay to kind of go back to it. But again, if you're on steroids or GVHD medications, you may need to discuss with your primary care physician regarding, or your transplant physician regarding, the risks and benefits, also the infectious disease doctor. But usually you wear a mask, gloves. The last thing you want is to get an infection as a mold infection. So, but I tell my patients usually after 1 year is okay.
Thank you. All right, this is a multi-part question. I'll try to do it in pieces here. If you have an allo transplant, is it true that all your childhood immunities get wiped out?
Yes. It's pretty much when you have an allo, it's a donor cell. So yes, you essentially, they give you a medication beforehand to wipe out your immune system essentially. And then you get the donor cells, and so that's why you need to be re-vaccinated.
Okay, and then she asked, but why doesn't CMV or EBV get wiped out? And is there any benefit of having your, is it titers checked?
So, okay, yeah, good. So CMV and EBV, so those are viruses that live inside your body. The moment we wipe out whatever kind of suppression you had of those viruses because of your own immunity, the viruses can come out and cause destruction. So that's why you're put on prophylactic medication. EBV, unfortunately, does not have any prophylactic medication. So for an infectious disease doctor, there's no real treatment we can give. It's just something we have to monitor. But CMV, we have a prophylactic medication to give him. They will usually give it to you if you have it. So when you wipe out your system, you're unfortunately causing the CMV to come out. That's why we give you an antiviral prophylaxis. CMV, HSV are the same way. Chickenpox, VZV is the same way as well. So when you get chickenpox and it turns into shingles, it always lives in your body. You can never get rid of it, and you have to just suppress it. So that's why you have to make sure you take those prophylactic medications. And what was the second part of the question?
It was a benefit of having your, is it titers checked?
Titers.
T-I-T-E,
yeah. So instead of titers, actually, what you want to do is check a PCR level. It's called CMV PCR or HSV PCR in case you do have an outbreak of herpes. But CMV, they'll check you every 2 weeks or a week for it to make sure that you're not getting a CMV infection in the blood. Typically, anybody that comes in for a fever and is post-transplant, I will check them, especially if they have a history of CMV. I'll check their CMV PCR because you can always break through your prophylactic medication too, or if you're not on prophylaxis, it may come out and you may have a new infection with it.
Okay, thank you. Next question, and this might be, we might have time for one or two more. Where are some of these infections coming from that are not food related? For example, vaginal candida, bladder, or kidney infections?
So, yeah, good question. So candida is actually in your body. Everyone has it. Everyone will always have it. It's actually, it's good. Candida is actually normally found in the vaginal canal already. But however, when you take antibiotics, you're on prophylactic antibiotics, you suppress the bacteria that are keeping the fungus at bay, and then you end up, the candida decides, okay, there's enough room for me to grow, so it'll start growing out. Bladder and kidney infections, basically, it depends. You know, being female and older, you can always develop bladder infections because of just, unfortunately, drier skin down there and things like that. A lot of times it can come from post-coital, so after having sex, people can develop it. But it's just one of the things, unfortunately, that will continue to happen. And it comes from other parts of the body a lot of times, too. So your body has bacteria and fungus in it, and eventually it can sneak into bad spots if not, if not controlled and such. And especially when you're immunosuppressed, it does that more often. So.
All right, thank you, Dr. Shah. I think that's going to have to be our last question of the day. So on behalf of BMT InfoNet and our partners, I'd like to thank you, Dr. Shah, for your very helpful remarks, and thank you, the audience, for your excellent questions. If you have any questions, please don't hesitate to contact BMT InfoNet, and I will let you know that this afternoon at 2:45 Central Time, there will be a workshop, COVID-19, What Transplant Survivors Need to Know in 2022, presented by Dr. Wingard of the University of Florida Health Cancer Center. So to build on some of the information that Dr. Shah gave us, there will be a whole nother workshop. So thank you all very much.
Thank you.